water bottle.
Normal temperature.
Okay.
Thank you. Don't mount it. Yeah. Good evening, good morning to everyone, and welcome to today's wonderful morning with Dr. Murali Bharadwaj. How to make a revision of obstetrics and gynecology in 2 days, in about 7 to 8 hours. That is the real challenge before the exam. So yesterday we finished obstetrics in 4 hours. Today we will finish gynecology in 4 hours so that you get 15 marks. That is a goal. Huh? Now, what is the homologue of the scrotum? Labia majora. And the round ligament, the supports of uterus, we write. It ends in labia majora. Then, if we look at the Bartholin duct, where is it located? It is in the posterolateral part to the vaginal orifice, where the Bartholin duct will open, whereas Keen's ducts, which are paraurethral glands, they open near the urethral meatus. So what is the nerve supply of vulva, doctor? Pudendal nerve. And lymphatic drainage is into the inguinal lymph nodes, and blood supply of the vulva comes from internal pudendal artery is what we need to remember. Now, a 30-year-old, there is a labial structure noted posterior to the vestibule in a thin horizontal fold. What is that? That is called faucet. The posterior fusion of the labia minora. 28-year-old has visible nodular scars in the posterior vestibule. What are they? They are called carunculae myrtiformis, which are the healed hymenal lacerations are called carunculae myrtiformis. Now, once more. What are homologous glands between the male and the female? Is a favorite question. Prostrate gland in the male. What is the female homologue? Skene's paraurethral glands. Cowper's gland in the male. What is the homologue? Bartholin's gland. Glands of Litta. In male, the homologue is the glands of the labia minora is what we need to remember. Now, if you look at the development of the vagina, upper 4/5 is developed from paramesonephric duct to this Mullerian duct, whereas the lower 1/5 is derived from the urogenital sinus. So, urogenital sinus is endoderm, paramesonephric duct is mesoderm. That's how vagina is a potpourri of two types of germinal tissues. What is the length of vagina? Anterior wall is 7 centimeter, posterior wall is 10 centimeter, and epithelium is non-keratinized, stratified squamous epithelium is what we need to remember. Now, what are the Dordalene spacula? They produce the lactic acid from the glycogen and they maintain the acidic pH of the vaginal milieu is what we should remember. Now, a 20-year-old presents which part of the vagina is derived from the endoderm? Favorite question. Lower 1/5 is derived from the urogenital sinus, which is the endoderm. Now, doctor, the blood supply, relations, and uterus orientation is a favorite question. Now, if you look at the hormonal smear, whenever we need to take a smear, It is the lateral wall of the upper one-third of the vagina is most hormone sensitive. Estrogen ఎక్కువ ఉన్నదా, progesterone ఎక్కువ ఉందా? How will you know? By looking at the cellular morphology of the vaginal wall. So the lateral wall of the upper one-third of the vagina is most hormone sensitive. Right? Now, if you look at the vagina, anterior part and posterior part. The anterior part is in relation to who is vagina के आगे क्या है? Bladder. Upper 2/3 by bladder and lower 1/3 by the urethra. Then posterior relation is upper 1/3 by the pouch of the Douglas and lower 1/3 by the ampulla of the, middle 1/3 is ampulla of rectum and posterior relation is lower 1/3 is perineal body. And what are the lateral relations? Upper 1/3 by the Meckenroth's ligaments and pelvic cellular tissue. And lateral relation, middle 1/3 is levatorani. And lateral lower 1/3 is bulbocavernosus, vestibular bulb and Bartholin's glands. So now, if you look at the venous drainage, it goes to internal iliac veins. Upper 1/3 of the vagina is sympathetic nerve supply, lower 2/3 is somatic, that is pudendal nerve. Very important. Lymphatics. Upper 1/3 of the vagina drains into external and internal iliac lymph nodes, and middle 1/3 into internal iliac lymph nodes, and lower 1/3 into superficial inguinal lymph nodes is something that you need to remember. Okay, doc? So, totally there are about 100 tables that you need to master. Miko, you won't take more than 100 minutes. Second revision. You need to catch what are those 2-3 points that I need to keep in deep to my heart when I go for the exam. Okay? Now, doctor, coming to the histology, innovation supports. Submucosa of the uterus, if you take, there is no submucosa for the uterus. It is absent. And endometrium directly lies on myometrium. And what is the endometrial lining histologically? It is ciliated columnar epithelium is what we should remember. Now, coming to the cervix histology. These are all favorite questions of the examiner, doctor. Nice to see 3 online classmates. Can you please punch? Is the voice loud and clear for all of you, doctor? Please. Yes. Supravaginal part of the cervix. यूट्रस का सर्विक्स के बाद आएगा वेजेना. वेजेना के ऊपर जो रहता ना, that immediate wala cervix, that has got simple columnar epithelium, whereas the vaginal portion has got stratified squamous non-keratinized epithelium, and between the two you have the squamo-columnar junction, and that is the most common site where you get the cervical carcinoma. In India, very frequent cervical cancer, right? Now, this is another favorite question. What is the corpus to cervix ratio? Uterus corpus together mottam. So typically 1:2 in children, 2:1 in adults, and postmenopausal it become 1:1. This we need to remember. Now, uterine artery is a branch of the internal iliac artery. Internal iliac artery has an anterior division, posterior division. So anterior division of the internal iliac artery is the one which gives rise to the uterine artery. And uterine artery, after originating from the internal iliac, has a very close relationship with the ureter. It runs above ureter. So what will all obstetricians, when they are learning, gynecologists, while they are doing hysterectomy, to clamp the uterine artery, they end up in clamping the ureter. They injure the ureter, and their fiancé who is doing MS general surgery will come and rescue them on a lighter wing. So I asked We used to have nice to see Priya Rai, Ramesh, and many more who are all online every day, early morning, 5 a.m. to 9 a.m. 5 o'clock is called Brahma Muhurat. That is the time where all our physiology is intact. Across the day, there are so many, that patient not well, this patient is weaning out of ventilator. Somebody will pull, right? So we are free from temptations where our body is ready to learn, our body is ready to assimilate. Always is early morning, right, doctor? It is little harsh for the medical students to wake up early morning, 5 o'clock. But anything is a habit, doctor. Let me tell you, excellence is not a happening. It's only habit. So from tomorrow, let's make it a point, 5 to 9. Now, doctor, what is the sympathetic innervation? T5 to T6, and parasympathetic is S2 to S4. Now, upper part of the cervix is supplied by, there is a plexus called Frankenhauser's plexus. Right? Now, I mean the sensory supply of the entire cervix. Now, coming to lymphatics, very important. Upper cervix drain into external and internal iliac lymph nodes, and lower cervix into sacral, superficial, inguinal lymph nodes, including, inguinal lymph nodes is what we should remember. Now, doctor, what is the active support of the uterus from drooping down? It is a pelvic diaphragm formed by the levator ani is responsible. Whereas passive support is, it is the uterine axis. Uterus or cervix के बीच में axis रहता. Accordingly, the fundus may be antiflexed or retroflexed. Most commonly, it is antiverted and antiflexed. Right? So the uterus doesn't droop through the cervix in it. So please remember that. Now, favorite question. When undergoing hysterectomy while clamping the uterine artery, what should be taken care? Ureter. The ureter passes below the uterine artery. And the question, it's called water under bridge. Water under the bridge. Who is the bridge? Uterine artery. Ureter carries the urine, no? So water under bridge. Similarly, what is the histological transition at the transformation zone? It is columnar into stratified squamous at the squamo-columnar junction. Right now? Now, the next table, uterine supports fallopian tube and broad ligament. So, in this, what you need to remember is length of fallopian tube. It is 10 centimeter long. And what is the epithelium of fallopian tube? Ciliated columnar epithelium, and it has got PEG cells. Fallopian tube ka blood supply is important. Medial 2/3 is uterine artery and lateral 1/3 is ovarian artery. Why this is important? Because we do tubectomy. So we need to be very sure about what is the blood supply. Favorite question. And where will fallopian tube drain into? It drains into the para-aortic group of lymph nodes. Right, doc? Yeah. Just run through, but identify what I am going to forget. That's most important. So, now, the ligaments of the ovary, mesentery, and what is the innervation? Now, where is ovary? Ovary is in ovarian fossa. What is ovarian fossa made up of? Waldeyer's fascia on lateral pelvic wall. So, if you look at the ovary, most important thing to remember is what is the ovarian artery? Ovarian artery arises from abdominal aorta. And ovarian vein drains into IVC. So always remember, testis kani ovary gani. The venous drainage is called gonadal vein. So this gonadal vein on right side directly drains into IVC, but on left side they drain into left renal vein, and left renal vein drain into IVC. గుర్తుంటుందా? అందుకోసమే testis ఉంటాయి కదా, the pampiniform plexus that drains into the gonadal vein. On the right side, it directly drains into IVC, but on left side it goes and drains into left renal vein. So whenever any left renal cell carcinoma is there, it leads to traffic jam for the left renal vein from draining into IVC. That causes a back pressure on the left gonadal vein, and that leads to varicocele. Any rapidly developing left varicocele should make you suspect the possibility of renal cell carcinoma. Okay? Now, so all these MCQs you need to review, doc. Now, coming to ovarian blood supply. Ovarian artery arises from abdominal aorta. Ovarian veins already we discussed. Then comes the ovarian lymphatic drainage. Para-aortic group of lymph nodes. Right, doc? Now, coming to the these are all the things that you can review. Menstrual cycle. Already we discussed a great deal in obstetrics. Follicular is day 1 to 14. Remember always, in the entire cycle of the woman, ovulation ke baad it is fixed schedule. Ovulation is like a exam notification. దానికంటే ముందర మనం ఒకరోజు చదువుతాం, ఒకరోజు చదవం. One day we will read, one day we won't read. It is like what? Follicular phase. Now what phase we are in? Exam notification आ गया, fixed है. So typically day 15 to 28 is fixed. 1 to 14 will vary. Please remember that. So what will estrogen will do? During the proliferative phase, under the influence of FSH, daily the follicle will be growing and it will be producing the estrogen, and that is the reason on 12th day, very high estrogen of that fully grown follicle will cause a positive feedback on the pituitary to release the LH, right? So that lead to LH surge is what we need to remember. Okay. Now, how is the endometrial biopsy in follicular phase, which is also called proliferative phase? Straight glands, dense stroma, mitosis. For a secretory phase, tortuous glands, glycogen-rich vacuoles, coiled spiral arteries. ఎందుకు secretory phase के end में क्या होता? Fertilization नहीं हुए तो menses होता. इसलिए coiled spiral arteries, glycogen-rich vacuoles, and tortuous glands characterize. Right, doc? Then cervical mucosa, ఎట్లుంటే చెప్పండి? Thin, watery, and stretchable, called spinberkete at the time of ovulation. It becomes thick and viscous during the secretory phase when progesterone is very high. Now, when will implantation occur? On the day 20 to 24, and this is the short review. So just review these MCQs, doc. Now, enough page 25 or 227. Arey wow, what a good news. 10% download khatam. Wow. Nice to see 9 online classmates. रोजाना रोज मिलेंगे, रोज पढ़ेंगे, एक दिन कामयाब होके दुनिया को बताएंगे भाई 20 दिन हम रोज 5 बजे उठ के 9 बजे तक पढ़ाई किए. How many minutes? 10 minutes, huh? 20 minutes, 10% download. Means 30% in 1 hour. 3 घंटे में gynecology खत्म. There is nobody in the world who will make the gynecology easier and faster, right? This is the mother of all notes, doctor. आप बोल सकते कि डॉक्टर मुरली भरद्वाज टॉपर नोट्स. సో 3 గంటలు ఎవరైనా గైనకాలజీ పూర్తి చేస్తారండి? ఇంపాసిబుల్. టుడే ఇట్ ఈస్ పాసిబుల్ బికాస్ ద చాట్ జీపీటీ. Chat GPT knows what is good and not good for us. Now, doctor, corpus luteum, it secretes the estrogen and progesterone post-ovulation. Now, what is the effect of progesterone? Secretory phase hormone. It secretes and stimulates. It makes the glands secrete by stimulating them. It causes vascular development. It makes the spiral arteries curve up, is what you need to remember. If there is no fertilization, corpus luteum, what will it become? It will become corpus albicans. The progesterone levels will fall, and that lead to the development of the menses. So you need to review all these things, doctor. If you do ultrasound, what do you see? In proliferative phase, there is a triple line pattern, 6 to 10 mm endometrium. And during the menstrual phase, it is hyperechoic linear stripe, 4 to mm, 8 mm thick. And peri-ovulatory phase, maximum triple line appearance. So looking at ultrasound also, obstetrician can know, gynecologist can know that ovulation hone wala hai ya ho raha hai. Right? So all these values you need to remember, doctor. Then there is a lot of overlap between gynecology and obstetrics. But remember, out of 30 questions that come in gynops, एक question तो invariably आएगा menstrual cycle. You expect it, you go and attack it. When you go to the exam hall, no, you should look, where is my OCP question? Where is my cervical cancer question? Where is my endometrial question? So like that, like a soldier, you need to go duck, 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 you need to fire, right? So now, doctor, what is the role of FSH? FSH makes the follicle grow. It stimulates the growth of the antral follicles, and LH will trigger the ovulation, as all of you know very well. So what is the counterpart of the LH that we use in the infertility clinic in order to HCG is the one which is being used, right? Now, what is meant by luteal defect? Corpus luteum produces the progesterone, and if it is not adequately producing, that lead to the development of the miscarriage, is what we need to remember. Okay. Now, doctor, a 27-year-old conceives naturally. What maintains her corpus luteum in the first trimester? It is the HCG. Maintains until placenta takeover. What is the size of the dominant Graafian follicle? In every class, there is one dominant boy, dominant girl. So that dominant Graafian follicle, which is destined to become the Queen of England, is Graafian follicle. And the size of it is 18 to 20. So what will infertility specialists will do? Regularly they monitor the size of the follicle until the Graafian follicle size has reached 18 to 20. That means it is ready to undergo ovulation, and the time to pick up the egg is what we need to remember. Now, doctor, inhibin, gonadotropins, and menstrual one-liners that we need to remember. What is the peak level of the LH at the time of ovulation? More than 7.5 nanogram per ml. See, this value, no, gynecologists, dearest value. And for the women who are conceiving, no, how is my LH, how is my LH, how is my LH? Utna important hai 7.5. Okay? Now, inhibin. Inhibin A, inhibin B. Inhibin A produced by corpus luteum and in the luteal phase by placenta. Inhibin B secreted by granulosa cells in follicular phase. Inhibin A will peak during the mid-luteal phase and inhibin B will peak during the mid-follicular phase. Now, what is the function of inhibin? Inhibin inhibits FSH secretion selectively. See, in the mid-luteal phase, no, you should have what? In mid-follicular phase, you need to have more amount of LH and less amount of FSH. But estrogen into doctor. FSH keep on stimulating making the follicle grow. Once the follicle reaches a particular full size, somebody should tell you stop FSH, you start LH. Who will do that? It is which type of inhibin? Inhibin B. Similarly, during the post-ovulatory phase, you don't want estrogen. You want progesterone. Who will tell that? Inhibin A is what we need to remember. But ultimate purpose is what? A or B, they will basically inhibit the FSH. Take it out. Now, sir, review cheyandi. Which hormone is selectively inhibited by inhibin B during the follicular phase? FSH. There is a mid-cycle abdominal pain. Which prostaglandin lead to dysmenorrhea? PGF2 alpha is the one which is responsible. So what is the function of LH in case of males? Males LH will stimulate Leydig cells to produce testosterone. FSH stimulates the Sertoli cells, which support the spermatogenesis is what we need to remember. Right down. Now, what are the GnRH agonists and analogs? Favorite question of the examiner. What is gonadotropin releasing hormone? The one which stimulates the FSH LH to get secreted is called GnRH. Who produce GnRH? In the hypothalamus, there is one arcuate nucleus which produces the GnRH. GnRH, if you give pulsatile way, it will increase FSH LH. GnRH, if you give continuously, it will decrease the FSH LH. Remember that. So why this property of the GnRH is exploited by the infertility specialists? What infertility specialists will be doing is, they want to make the follicle grow by exogenously administering the FSH LH. For that, they don't want disturbance from endogenous FSH LH. They need to suppress it. Hence, they give GnRH continuously, suppress the endogenous FSH LH, take the control of the entire system, and they give the exogenous FSH LH. Right, Doc? Then what is the role of pulsatile FSH LH? Suppose if the woman's gonadotropins are all good, then better stimulate them. Stimulate the GnRH to make their own endogenous FSH LH to get stimulated. For that, exogenously they give the pulsatile GnRH. So accordingly, there are two protocols. Either you give continuous GnRH and suppress FSH LH and give exogenous FSH LH, or give pulsatile way and stimulate the endogenous FSH LH. Good to that? So, what is Kallmann syndrome? In this, the hypothalamus fails to produce the gonadotropin releasing hormone. Because of that, their pituitary fails to produce the LH-FSH. Because of that, their ovary fails to produce the estrogen. So it is an example of hypogonadotropic hypogonadism. Along with that, they also have anosmia. They can't sense the smell. That combination is called Kallmann syndrome, is what we need to remember. So where do we use GnRH agonists? In polycystic ovarian disease, IVF, precocious puberty. Suppose, what is precocious puberty? Unnecessarily, there is a production of FSH-LH in precocious puberty. Even before the right time, in an 8-year-old girl, if the FSH-LH starts producing, how can you stop that? Give a continuous GnRH. That will lead to inhibition of FSH-LH. Okay? Now, in the males, GnRH agonists are used to decrease the LH level so that you can decrease the testosterone level, so that you can decrease the growth of the prostate in prostate cancer. Hence, we use continuous use of the GnRH agonist, is what we need to remember. Right? Now, what is HMG? Human menopausal gonadotropin. So, from the postmenopausal women urine, what will be very rich? Postmenopausal women urine will be rich in FSH-LH. Why? Because they don't produce estrogen, no, ovary. No inhibition on FSH-LH. That's the reason their FSH-LH is high. So menopause is a state of hypergonadotropic hypogonadism. Right? So that is the whole story. Right? Just to switch on this, plug on this panda, you are sure to win. Kallmann syndrome, etc., etc. Then comes estrogens, progesterone, and GnRH analogs. Now, are we fine, or a lot of repetition from obstetrics? A lot is there, but that is how the gynecology is created, right? Ivanni chadave manam. Already we finished. Istro, nistriol, estradiol, and who produces what and all that. We can just finish the revision of that. Now, one important few points we'll talk. If you give GnRH agonists, what is the purpose of giving them continuously? To suppress the endogenous FSH-LH production. But initially, they can cause a flare-up of FSH-LH production. That's called GnRH agonist flare effect. Whereas, instead of giving GnRH agonists continuously to suppress the pulsatile release of FSH-LH, another way of doing things is directly give GnRH antagonist. उसमें flare effect नहीं रहता, immediately suppress हो जाता. So what is the GnRH agonists and antagonists which are being used? Right? You need to know a little pharmacology. Neferelin, goserelin. What is neferelin? International GnRH agonist. Goserelin is the only depot injection form is available. They both are GnRH agonists, but if you use them, there is a chance of initial LH-FSH flare-up is there. Then luperolide, it is given as a daily or a depot subcutaneous or IM injection. So luperolin, luperolide, tiporelin, goserelin, neferelin. This GnRH agonist is one protocol. ఇంకో రెండో ప్రోటోకాల్ ఏంటండి? You can give degarelix and ebarelix, which are the GnRH antagonists, which are used mainly in case of prostate cancer to cause androgen deprivation. Okay, so just review these questions. right? Now comes estrogen, progesterone, and the SERMs. Kitava time?
35.
35 minutes. Good. Today we are going with like a super fast express. 40 pages out of ఎంత అండి ఇది 20% డౌన్లోడ్ ఖతం. ఎందుకంటే బికాస్ ఆఫ్ ద ఆప్షటిక్స్ ఈ చెత్త చదివినాం. ఎక్సెప్ట్ ఇవి గుర్తుపెట్టుకోండి ఒకసారి. ఏది మన నెఫరెలిన్, గొసెరెలిన్, వాట్ ఆర్ ద జిఎన్ఆర్హెచ్ యాంటాగోనిస్ట్ టిప్స్ మీద ఒక పెన్ ప్రింట్అవుట్ తీసుకుని జస్ట్ టిక్ దోస్ థింగ్స్ దట్ యూ నీడ్ టు డూ క్విక్ రివిజన్. అండ్ ఐఎమ్ టెల్లింగ్ యూ, obstetrics gynecology, you have nailed it down. Your score increases by 10. Already you are in a passing score. Then medicine, surgery. Surgery మొత్తం ఇట్లనే ఒక 300 pages ఉంటుంది, 2 days. You are another 10. Medicine we nailed down ఒక 5. ఎందుకంటే already you are good at medicine. That's the reason you are at least scoring that 42 or 43%. అన్ని కుట్టి కుట్టి సబ్జెక్టులు అవుతున్న కొద్దీ మీరు ఎవ్రీ డే ఆఫ్ అవర్ సెషన్ ఐఎమ్ అష్యూరింగ్ యూ అట్లీస్ట్ యూ విల్ గెట్ 5 marks extra. 20 days, 20 into 5 extra, 100 plus 142, 242 out of 300. You are on the top of the India map. సో అదొక్కటే పెట్టుకోండి డ్రీమ్లో. Sorry, I woke you up from a slumber. So, we are a team now. Sometimes team will have coercion. Now, estrogen is used in vaginitis. It will treat the atrophic vaginitis in case of the postmenopausal women. Estrogen, it is indicated whenever there is any delayed puberty for the breast development. Estrogen suppresses the lactation during the post-delivery. Why? Post-delivery high estrogen will go and inhibit the FSH-LH and that lead to high estrogen inhibits the prolactin, suppresses lactation. Now, estrogen is given in gonadal dysgenesis, Turner syndrome. What is Turner syndrome, doctor? Ovarian dysgenesis. Right? So in ovarian dysgenesis, when the ovary is not able to produce the estrogen, we give the estrogen to treat it. For dysfunctional uterine bleeding, we give estrogen. Estrogen increases the mucus hostility and impair the sperm transport. That is the purpose of giving estrogen as a contraceptive. Then estrogen is given as a hormone replacement therapy. They are all the uses of estrogen. Coming to progesterone. If you give progesterone for a while and then withdraw it if there is no bleeding, that means problem is there in the uterus, not with the ovary. But the progesterone withdrawal is able to induce the bleeding. That indicates that the cause is anovulation. Then progesterone is used in DUB. It controls the unopposed estrogen-induced bleeding. Progesterone is used in endometriosis. It will suppress the ectopic endometrial tissue growth. Very important. Estrogen promotes endometrium. Progesterone stops endometrium. We don't want endometrium to grow in endometriosis. That's the reason we give the progesterone. Luteal defect leading to miscarriage is because of the deficiency of progesterone. That's the reason we give progesterone to treat the luteal phase defect. Similarly, any woman who has endometrial hyperplasia, we want to attenuate all those endometrial glands, we give the progesterone. Progesterone relieves the premenstrual syndrome before menses. There's a lot of dysphoria, mood disturbances, everything. all due to the unopposed action of the estrogen, which is countered by giving the progesterone, is what we need to remember. Now, doctor, there are some SERMs. What are the SERMs? SERMs. Selective estrogen receptor modulator. For example, in the breast, if they antagonize the estrogen, in the endometrium, they agonize the estrogen. Clomiphene citrate is a SERM which will induce the ovulation. Normally, estrogen's function is what? To inhibit the FSH. But this is such a SERM that it will go and stimulate the FSH. Then tamoxifen is used in breast cancer. It is anti-estrogen in breast and pro-estrogen in endometrium and bone, is what we need to remember. That's the reason, because it is pro-estrogenic to the bone, it will promote the bone density, decrease the bone resorption, prevents the osteoporosis. They're all good things about tamoxifen on bone. Tamoxifen is good on the bone. Tamoxifen is good on the breast. Tamoxifen is bad on the endometrium. It can predispose to endometrial cancer. Clear, doctor? So, 25-year-old with irregular menses is evaluated for secondary amenorrhea. Progesterone is given for 5 days and she bleeds on withdrawal. Where the problem? Anovulation. Right, doctor? Now, it's simple and day. If you read to represent in exam, no challenge. But the problem is reading with that specificity to hit the jack's bull eye is everything about winning. Right, doctor? Now, tamoxifen in breast cancer. Tamoxifen can cause endometrial cancer. Tamoxifen prevents osteoporosis. That is the story of tamoxifen. Tamoxifen will anna evaru reloxifene. Reloxifene for osteoporosis. Reloxifene improves the lipid profile. Reloxifene reduces the fracture risk. And it is antagonist in breast and also in endometrium, unlike the tamoxifen. But reloxifene will increase thromboembolism, just like the estrogen. Then, fulvestrant is a selective estrogen receptor downregulator. Where do we use? Whenever the breast cancer is resistant to the treatment with tamoxifen, then we use fulvestrant. वो सीधा जाके estrogen receptor को क्या करेगा? Modulate नहीं करेगा, down regulating करके बिठाएगा. Then aromatase inhibitors, they inhibit the aromatase enzyme. Aromatase is the one which converts the androgen into estrogen. So letrozole, anastrozole, they're all non-steroidal aromatase inhibitors. Exemestane is steroidal and it leads to irreversible aromatase inhibition. And where do we use this letrozole? It is used for ovulation induction in the PCOD patients, just like clomiphene. Enduku normally estrogen goes and inhibits the FSH. Idem chestadi, this goes and stimulates the FSH by decreasing the estrogen levels, right? Because it's an aromatase inhibitor. It is also used for IVF. So it will prevent the premature LH surge in controlled ovarian stimulation. Okay, doc? So, ఇవన్నీ ఒకసారి రివ్యూ చేయండి క్వశ్చన్స్. దెన్ డాక్టర్, సో గుడ్ టు సీ. ఎంత 8? आज हमारा स्कोर 8 चल रहा है. Please punch. Is the voice loud and clear for all of you, doctor? Please punch your names. We'll be very happy to see you on this wonderful morning. Every day, 5 a.m. to 9 a.m., we will have a review. One subject khatam karenge, that is my promise. 20 days mein pura 19 subjects, khel khatam, dukan band. Right? Even if you did not read all the year, come to me and give yourself 20 days. सीट नहीं आए तो मेरा नाम मुरली भरद्वाज नहीं होगा. That's my guarantee. కొంచెం ఒక వాటర్ బాటిల్ తీసుకోండి. So, welcome back to the session, doctor. Now, amenorrhea and differential diagnosis of the primary amenorrhea. When do you call primary amenorrhea? If there are no menses by 14 years with no secondary sexual characters. If there are secondary sexual characters, if there are no menses until 16th year, you call it as primary amenorrhea. The most common cause of the primary amenorrhea is gonadal dysgenesis, turnus, most common cause. And the most common karyotype, 45X4. And the most common cause of secondary amenorrhea, pregnancy. Then what is testicular feminization syndrome? Fundamentally, they are karyotypically male, 46XY. But phenotypically, they are female. They have no uterus, they have a testis, but they have a normal breast development, but absent pubic and axillary hair. Why normal breast development? Fundamentally, what is their problem? They produce the testosterone from that ovary, but that is unable to act on the receptor. Because of that, it can't act on receptor. For the testicular descent, you require testosterone action on the receptor. So testis doesn't descend. Because they are karyotypically males, they have a Mullerian inhibiting substance. So Mullerian duct derivatives, which include the uterus, fallopian tubes and all, they won't develop. And all that testosterone become peripherally aromatized into estrogen, and anybody who has estrogen develops breast. So that is the reason there is a normal breast development, absent pubic and axillary hair, no uterus, but testis present. 46XY is the chromosome. And what will happen? Because their testis is not descent, it is intra-abdominal, right? And that's the reason there will be a blind ending pouch-like vagina. That is androgen insensitivity syndrome. Then you have a Mullerian agenesis, which is called Mayer-Rokitansky-Kuster-Hostner syndrome, which is 46XX. No uterus, no ovaries, but they have a normal blind vaginal pouch. Why? Because if you look at the development of the vagina, lower part is derived from urogenital sinus, which is endodermal. Upper part is derived from the Mullerian duct, paramesonephric duct. If the paramesonephric duct is not there, Mullerian duct is not there, the upper part of the vagina doesn't develop, and what you see is only the lower part of the vagina is what we need to remember. Okay, doc?
Yes.
Now, how is their breast? Normal breast, normal pubic and axillary hair. Okay, now, next cause of amenorrhea is Turner. Streak gonads, undeveloped breast, because if they don't have gonads, gonadal dysgenesis, if it is there, there is no estrogen. If there is no estrogen, there is underdeveloped breast. They have a webbing of the neck, 45X4. And what do they have? I mean, how is their FSH LH in Turner's? Quick answer. Low, na?
Yeah.
Hey. If the ovary is not producing estrogen, nobody to inhibit, no? So what do you get? Hypergonadotropic hypogonadism. Then there is another entity called hypogonadotropic hypogonadism. That is Kallman syndrome. ఇక్కడ GnRH ప్రొడక్షన్ ఉండదు, అందుకోసం LHFSH లో, అందుకోసం estrogen లో. So don't forget, favorite question. Turner syndrome, what is that? Hypergonadotropic hypogonadism, whereas in the case of Kallman's it is hypogonadotropic hypogonadism. Right, doctor? Now, so absent uterus, normal ovaries. Mayer-Rokitansky custom host. Why? Because this is Mullerian agenesis, and Mullerian ducts have nothing to do with the ovary production. Ovaries are not derivatives of Mullerian duct. Only uterus is the derivative. Upper part of the vagina is derivative. Absent uterus, absent testis. Absent uterus and presence of testis is absent uterus, presence of testis which could not descend down is androgen insensitivity syndrome, which is also called testicular feminization syndrome. Then normal uterus plus delayed puberty is hypogonadotropic hypogonadism. Their Mullerian duct, everything is intact. Then primary ovarian failure, most common cause any day is Turner, which is gonadal disgens. Gurtunte doctor sir? Sure shot of a question illa raakunte हम एक्सेप्ट नहीं करेंगे एग्जामिनर को. ఇప్పుడు చెప్పండి 15-year-old girl, primary amenorrhea, normal breast development, absent pubic and axillary hair, blind vaginal pouch, ultrasound show absent uterus with intra-abdominal gonads. Classical of androgen insensitivity. So దూకి పెట్టాలి. 16-year-old girl, primary amenorrhea, well-developed secondary sexual characters, uterus is absent, both ovaries are seen in the normal position. Ovaries have nothing to do with the Mullerian duct. It is an example of Mullerian agenesis. A girl presents with delayed puberty and anosmia. She has a low FSH/LH, is hypogonadotropic hypogonadism, that is Kallmann syndrome. All right, doc. Compulsory in the lens of a question, it will digitally exam. Very good. Can the online students can punch the voice loud and clear, doctor, for all of you? Now, Swyer syndrome, androgen insensitivity syndrome, Mullerian, Mayer-Rokitansky. Once more, we need to be very sure. What is Swyer syndrome, doctor? Swyer is just like androgen insensitivity, XY karyotype. In this, there is a mutation of SRY gene. What is SRY gene? SRY gene is the one which is responsible for male Wolffian duct to develop and Mullerian duct to become absent. SRY gene mutation undi, even though if it is, why males are males? Because we have Y chromosome. If Y chromosome is there, why are we males? Because those who have Y chromosome have SRY gene. SRY gene will cause Mullerian inhibiting substance that will cause Mullerian duct to not develop and Wolffian duct to develop, and we have all the male organs. But even though XY is there, but if SRY gene is mutated, absent, then what will happen? There is nobody to stop the Mullerian duct to develop. That's the reason phenotypically they are female, is what we need to remember. That is called Swyer. So Swyer presents at puberty with a normal stature, primary amenorrhea, no breast. If you take out the gonad, they have a streaky gonads, removed early due to malignancy risk. That's the story of Swyer. How do you treat them? Remove their ovary and give exogenously estrogen, progesterone, use it to induce the puberty and menstruation. So they are karyotypically XY. But because SRY gene is not there, Mullerian inhibiting substance is not there, Mullerian duct developed, they have full apparatus to conceive. Right? But they don't have the ovary well developed. Because they're XY, no? XY guy ko ovary kaise rehta? Funda? Swyer is very interesting. Because XY, ovary is not well developed. So you remove that ovary, otherwise it will become malignant. And what you do, because they have full apparatus to become a mom, you try to do a her his by her sister to provide the oocytes, and his by her husband will donate the sperm, and that embryo in IVF you bring and make her conceive, and she can grow that. Got me? Both AIS and Swire are similar. Both are phenotypically female because the development of the breast with 46XY. But differentiation, AIS may, androgen insensitivity syndrome may, no uterus. Swire may, they have uterus but with streak gonad. Got me? Why they have uterus? Because their SRY gene is defective. There is no Mullerian inhibiting substance. That's the reason Mullerian duct developed, and all the Mullerian duct derivatives like uterus, everything is available for her to grow the baby. That's the difference between the two. Favorite question. Swire versus AIS. Ardhamainda? Any doubts? Pakka. कल के एग्जाम में आंसर करोगे ना? Good doctor. Half century over. At any time, Ganta? 1 hour? Here. Anthony, number?
103.
103. Right. 1 hour, 50 pages, eh?
Yes.
So, మొత్తం ఎంత కింద 220.
Yeah.
అరే వాట్ ఐ వండర్ 4 hours పక్కా ఉందా ఓపిక? సో let's come back. So, that's the story, doctor. So, ఇది కొంచెం రివైజ్ చేయండి. నెక్స్ట్, dysmenorrhea. What is meant by dysmenorrhea? Painful menstruation. Primary dysmenorrhea. It is caused by increased prostaglandins that will make the uterus tumultuously contract, and that lead to dysmenorrhea, primary end. But what is secondary dysmenorrhea? if there is any endometriosis with ectopic endometrial tissue implanted in the parametrial area, parametrial tissues, they develop dyspareunia, dysmenorrhea, etc. Pelvic inflammatory disease will make the uterus become tender and dysmenorrhea. Fibroids can cause secondary dysmenorrhea. How is the primary dysmenorrhea pain? The pain begins before or just with the menses. It will be cramping. Whereas in the case of secondary dysmenorrhea, the pain is progressive, worsens over a period of time, often with dyspareunia. And what is the site of the dysmenorrhea pain? It is in the lower abdomen, suprapubic area, and that is the story of dysmenorrhea. Dysmenorrhea pain, eప్పుడు start with the doctor? Pain begins before or just with the menses, with cramping, that every woman suffer. So what is the treatment of primary dysmenorrhea? Give NSAIDs, right? And OCPs. They are the first line treatment. Now, 16-year-old girl presents with primary amenorrhea, normal breast development, scanty pubic hair, no uterus or on imaging. Karyotype is 46XY. Come on, tell me, what is the answer? Beautiful. You'll remember me in exam hall when the question comes. 15-year-old girl with primary amenorrhea is found to have normal stature, no breast development, normal pubic hair, and a uterus on ultrasound. Karyotype is XY. What is that syndrome? Calvin, anosmia untadi, hypergonadotropic hypogonadism untadi. Don't disappoint me. Instead cheppinam adi ani. Androgen insensitivity syndrome aithe breast develop aithe kada.
Yeah.
You're the chief gynecologist, doctor. Come on, tell me. Uterus and ultrasound, in spite of having 46XY, that means Mullerian system developed in them because of the absence of Mullerian inhibiting substance, because of the defect in SRY gene, which is called Swyer syndrome. Please, doctor. వాళ్ళకి గొనాడెక్టమీ చేసి IVF చేయొచ్చు with his or her sister giving eggs. Okay? Please don't do mistake of this. Now, 22-year-old woman complains of crampy lower abdominal pain starting just before menstruation. What is that called?
Primary listening.
Very good. Very good. Now, doctor, abnormal uterine bleeding. The Federation of Gynaecologists Association, FIGO, International Gynecologists and Obstetricians Federation, palm coin classification, chaudam. Right? Menorrhagia means what? Normal 25-day cycle with increased blood loss, both in duration and also quantity. Polymenorrhea, cycle is less than 21 days, frequent menstruation. Oligomenorrhea, cycle more than 35 days, often with decreased flow. Metrorrhagia, it is intermenstrual bleeding, irregular bleeding between cycles. Hypomenorrhea, it is a normal cycle but a decreased flow. Cryptomenorrhea, menstruation without any visible blood because of the imperforate hymen. Precocious menstruation, if the menarche starts before 10. इवన్నీ definition doctor साहब दिल लगा के याद रखना. So FIGO's AUB classification is replaced by DUB. Abnormal uterine bleeding, dysfunctional uterine bleeding అన్నారు ఇప్పుడు. With the palm coin system in 2011. Right? సో పామ్ అంటే ఏంటండి? AUBP. If there is a polyp, there is a abdominal uterine bleeding. AUBA, whenever there is an adenomyosis. Adenomyosis అంటే ఏంటి?
ectopic growth
Of endometrium into myometrium. AUBL is leiomyoma, most common cause of structural AUB. AUBM, malignancy or hyperplasia. AUBC, because of the coagulopathy like von Willebrand disease. తెలుగు హిమోఫిలియా ఎవరిలో ఉంటుంది? బాయ్స్ గర్ల్స్? ఎందుకు? X linked. But von Willebrand disease is autosomal recessive. Both boys and girls can get. Any girl presenting with bleeding diathesis is given in the exam hall. Examiner is pointing to von Willebrand disease. Any boy with bleeding diathesis, hemophilia. AUBO is ovulatory dysfunction. AUBE, endometrial cause. AUBI, iatrogenic, caused by OCPs and anticoagulants and IUDs. AUBN, not yet classified. Put it to the palm coin. DUB అనేది జమానాకి టర్మ్. సో మళ్ళా డియూబీలో రెండు రకాలండి. ఎనోవ్యులేటరీ డియూబీ, a dysfunctional uterine bleeding caused by anovulation versus ovulation. Between the two, which is most common? Anovulatory DUB is 80%, 20% is only ovulatory DUB. Come on, ఇప్పుడు చెప్పండి ఆన్సర్. 14-year-old girl with irregular heavy periods since menarche cycles are painless, occur every 2 to 3 months. What is the most likely FIGO category? చెప్పాలి. E అంటే ఎండోమెట్రియం, C అంటే O అంటే ఓవ్యులేటరీ డిస్ఫంక్షన్, C అంటే కోయాగ్యులోపతి. చెప్పండి ఆన్సర్ ఏంటి? పద్నాలుగేళ్ళ అమ్మాయిల బ్లీడింగ్ డయాథసిస్ ఉంటుందా? కోయాగులేషన్ డిఫెక్ట్. ఈ అంటే ఏంటండి డాక్టర్ సాబ్? ఎండోమెట్రియల్ కాజ్ లైక్లీ ఉంటుందా, లేకుంటే లియోమయోమా ఉంటుందా, ఆర్ ఎనోవ్యులేషన్ ఉంటుందా? తొందరగా చెప్పాలి. అంతే. Then 38-year-old woman with menorrhagia, ultrasound shows fibroid. What is the FIGO classification? Huh? Oh, it's called L and leiomyoma ane fibroid. మరి సగం మంది పిల్లలకి తెలియదు ఇది. పరీక్ష పోతే ఏంది బాబు ఈ ఓ ఏంది, ఎల్ ఏంది, ఈ ఏంది, సి ఏంది అంటారు. రివైజ్ చేస్తారా మరి? ప్లీజ్ సార్. I don't go to battles that I lose. But if I wage battle, I'll only win. That's the rule. So, కాబట్టి my present battle is you. We have to win. అంటే కొంచెం మీరు సహకరిస్తే కొంచెం మంచిగా ఎట్లనైనా చేసి ఒకటే ఒక డ్రీమ్, ఆల్ ఇండియా ఇన్స్టిట్యూట్ ఆఫ్ మెడికల్ సైన్సెస్, శ్రీ చిత్ర తిరుమల్ విన్నర్, టాప్ మోస్ట్ ఇన్స్టిట్యూట్ ఫర్ ఇంటర్వెన్షనల్ రేడియాలజీ. My dream that you are there. Into sir, too many people have dreams about me. I myself is not sure. Anem legada. You personally, proactively, you have a war. I feel. Kada? You are not playing other wars. A woman on warfare in presence with heavy menstrual bleeding. What is that called? AUB? Good. Nice. Intelligence, memory, recall la asalu dokale. I have 200% confidence. Then first 1 week lone I would have said no. If those primary defects unte em cheyalem. Question is that of conviction to persevere. టెస్ట్ చేయాలి రోజు అంటే చేయాలి డాక్టర్ సాబ్. మనము ఫుడ్ స్కిప్ చేసిన పర్వాలేదు కానీ ఈ అకాడమిక్ మైల్ స్టోన్స్ ఉంటాయి కదా అవి ఖతం చేసి వై ఐ కాంట్ డూ అది దట్ షుడ్ బి ద గోల్. నౌ ఎనోవ్యులేటరీ డియుబి. What is the reason? Estrogen is unopposed, leading to endometrial hyperplasia. In anovulatory DUB, progesterone is low because progesterone only comes if the corpus luteum is there, if there is an ovulation. If there is no ovulation, no progesterone. Progesterone is low, no secretory transformation. Where do you see anovulatory DUB? Puberty, perimenopausally. Then what is metropathia hemorrhagica? It is a kind of anovulatory DUB where the endometrial glands will undergo a cyclical glandular hyperplasia, typically between 40 to 45. They present with amenorrhea, a middle-aged woman presenting with amenorrhea followed by excessive bleeding due to unopposed estrogen. Estrogen, ఎనోవ్యులేషన్ వల్ల టూ మచ్ ప్రొడ్యూస్ అయ్యి టూ మచ్ ఎండోమెట్రియం గ్రో అవుతుంది లైక్ ఎ డెన్స్ ఫారెస్ట్. అది ఒకటేసారి బ్లీడ్ అవుతుంది బయటికి. సో ఎమినోరియా ఫాలోడ్ బై మెనోరేజియా బికాస్ ఆఫ్ ది అన్అపోజ్డ్ ఈస్ట్రోజన్ యాక్టివిటీ ఈజ్ మెట్రోపథియా హెమోరేజికా. If you look at the microscopy of metropathia hemorrhagica, what do you see? Dilated glands, Swiss cheese. What is Swiss cheese? Cheese with perforation is called Swiss cheese. Swiss cheese pattern with cystic changes is metropathia hemorrhagica. Whenever there is any anovulatory DUB, what is the treatment of choice? If it is an adolescent girl, give cyclical medroxyprogesterone. But if it is an active female, give dipomedroxyprogesterone or OCP. The whole idea is what? You give progesterone, withdraw the progesterone, and that lead to bleeding. So how long you need to give progesterone? It is typically given between 12 to 14 days of cycle. Between proliferative and secretory, which is fixed one?
The ovulation is fixed.
Post-ovulatory na pre-ovulatory na?
You post.
After notification, fixed. Before notification, we can do anything. What into that? Very good. Now, if there is any ovulatory DUB, NSAIDs, mefenamic acid is the drug of choice. Then, what are the indications for surgery? When the medical treatment is failing with dysmenorrhea, severe pain is there, then or childbearing is complete, then you can do surgery. So there are a lot of women with very severe dysmenorrhea who prefer to go to early hysterectomy, unable to manage the pain with every menses. Right? Now, what is the gold standard surgery for dysmenorrhea? Hysteroscopically, you will go and resect that endometrium. Hysterectomy ana cheyochu, lekunte endometrial resection ana cheyochu. Okay? Now, don't forget that Swiss cheese pattern. Now, there is another way by which you can do endometrial ablation if there is any dysmenorrhea. How? You can put a levonorgestrel containing intrauterine contraceptive device. You know, progesterone is anti-endometrium. So, it will locally release the levonorgestrel, thin down the endometrium, reduces the bleeding, and that's how you treat there is a non-contraceptive indication for IUCD is dysmenorrhea. Okay? Now, a 15-year-old girl with irregular heavy bleeding for the past 3 months is found to have anovulatory cycles. She is not sexually active. What is the best treatment, doctor?
Medroxy.
Very good. Cyclical medroxyprogesterone. Right? Now, 40-year-old woman, amenorrhea for 2 months, followed by sudden heavy bleeding, endometrial biopsy show cystic dilatation with Swiss cheese pattern. What is the diagnosis? Hemorrhagic. Examiner, he will peel out the orange and put in your mouth. Ready? Ada cow. If you are a prepared student. Otherwise, you don't get that cue. Right?
Sir, will you have breakfast?
No?
Breakfast symptoms. Oh, no.
Unless you are hungry.
No, I'm fine.
No. Now, doctor. 40-year-old women with amenorrhea for 2 months, followed by sudden heavy bleeding, cystic dilatation, metropathia hemorrhagica. Ippudu idi correct pedthe meeru, I will give you gold medal.
6-year-old completed.
Chronic DUB unresponsive to medical therapy.
Ablation.
Endometrial ablation. Beautiful. Right? Now, doctor, a very important topic is postmenopausal bleeding. Bleeding after 12 months of amenorrhea in a middle-aged woman is definition of postmenopausal bleeding. The most common cause is endometrial and vaginal atrophy, not necessarily the CS cervix, but we need to suspect. Vaginal atrophy untadi post menopause, and that lead to the development of postmenopausal bleeding. Then most common cause of the PMB in developing countries is CA cervix, right? CA cervix more than CA endometrium. Developed countries, it is the endometrium. What percentage of the postmenopausal bleeding cases have endometrial cancer? 15%. So what is the first investigation? Do the transvaginal ultrasound and then look how is the endometrial thickness. If the endometrial thickness is less than 4, then it is low risk. If the endometrial thickness is more than 4, what do you want to do? Proceed to hysteroscopy, do biopsy or fractional curettage. If the endometrial thickness is less than 4 mm and there is a recurrent postmenopausal bleeding, then perform endometrial aspiration even though the endometrial thickness is thin. If the endometrial thickness is less than 4 mm, no recurrence, then just observe. No further action. So how do you do endometrial sampling, doctor? We use a Pipel biopsy or dilatation curettage. Mala a Pipel biopsy jese idunte kada gadget. Go through the Google. They will ask that image. Right? So average age of menopause is around 51 years. It comes earlier if you are a smoker. Premature menopause is if it comes before 40. And most common symptom is hot flushes is the most common. There's a low estrogen, high FSH, high LH characterize the menopausal hormonal profile is what you need to remember. So what are the complications? Havoc, hot flushes, atrophy of vagina, vaginal dryness, and osteoporosis and coronary artery disease. Right? So now, doctor, quick go. Endometrial thickness 2 mm, spotting per vaginum. What is the next step?
It's normal.
Reassurance, absolutely. Then 58-year-old women with postmenopausal bleeding and endometrial thickness is 7 mm.
Biopsy.
Biopsy. 48-year-old smoker presents with amenorrhea for 14 months, vaginal dryness, hot flushes,
Menopause.
menopause. Huh? Menopause.
Yeah,
Not premature.
less than 40.
Less than 40. Beautiful. Right, doctor. Now, menopause, HRT, and imperforate hymen is our next journey. ఎన్న పేర్లు ఉన్నాం డాక్టర్ సార్
62.
82 ఇక్కడ కింద
62.
62 అమ్మా స్లో డౌన్ అయినా యా నౌ most of these things are already discussed,
Yeah.
right? Hormone now most common. What's more? What is serum estradiol cutoff to call it as menopause? Less than 20 picograms. Vaginal histology lo emuntadi? Vaginal smear shows a maturation index of 10/85/5. What is the meaning of 10/85/5? Superficial, intermediate, basal cells. 3 types of cells will be there. What percentage of these cells will vary depending upon how much estrogen is available. Accordingly, you get 10/85/5. ఇది ఒకసారి చూడండి how 10/85/5 vaginal cytology looks like. ఇది గూగుల్ నిన్న బుక్ తీసుకొచ్చారు ఇవాళ బట్
Yeah.
So what is the first line of treatment of menopause? Hormone replacement therapy, where you will give both estrogen and progesterone. Hip fractures decrease, hot flushes decrease, improves the sleep, improves the libido, husband is happy if you give HRT. But HRT can increase the risk of stroke, thromboembolism, endometrial cancer. Now, what are the non-hormonal alternatives to treat the menopausal symptoms? So there are a lot of mood fluctuations in menopausal women. So selective serotonin reuptake inhibitors. Chapani quickly, what are all they? Fluvoxetine, paroxetine, escitalopram, marchipod. Similarly, gabapentin, clonidine, vitamin E, even non-hormonal. So how do you treat osteoporosis, doctors? You can give biphosphonates, but today modern medicine is denosumab, 60 milligrams. Every 6 monthly subcutaneous injection. Calcium and vitamin D. That's the story. Now comes imperforate hymen. Failure of the central hymenal membrane presenting with primary amenorrhea with cyclical abdominal pain between 14 to 16 years of age defines the presentation of imperforate hymen. When you clinically examine all the blood collected, we find that imperforate hymen will lead to hematocolpos, hematometra. All that blood will go back. Parametrial tissues like accumulate aitadi. Fallopian tube mein accumulate ho jata. Hematocolpos, hematometra, cryptomenorrhea, they're all the feeling. They're all the findings. So bulging bluish membrane plus tenderness is the classical feature. And never do pervaginal examination is strictly contraindicated. in imperforate hymen. Right? So these are the questions, doctor. Try to do a quick revision of these questions. Now comes hormonal replacement therapy. If you do hysterectomy also, you do hormonal replacement therapy, but there give only estrogen. Why? First of all, in hormone replacement therapy, in a woman without hysterectomy, why do you give progesterone?
Hot flushes.
Uh,
No.
if you only give estrogen, it lead to endometrial
Cancer.
cancer. ఇక్కడ ఎండోమెట్రియమే లేదా?
Yeah.
సో అందుకోసం give estrogen only HRT in case of the woman with post hysterectomy. Then what is tibolon? It is used to treat hot flushes and osteoporosis. What is the meaning of STEAR? చూడండి. See in Google. What is STEER? STEER అంటే ఏదో ఉంటుంది. Selective STEER. What is the full form of STEER? Anybody in online can give the answer. STEER का मतलब क्या होता है?
Selective tissue estrogenic activity regulator.
Huh?
Selective tissue estrogenic activity regulator.
So selective tissue estrogen activation activity regulator. Tibolon is used for hot flushes and osteoporosis. Raloxifene is used for osteoporosis but not for hot flushes. So what are the absolute contraindications? Favorite question of the examiner for HRT. Undiagnosed vaginal bleeding, estrogen-dependent cancers, and any active liver disease. Right? And what is the definitive proven risk of giving HRT? Stroke, coronary heart disease, breast cancer, DVT, gallstones. And what is the uncertain benefit of HRT? Colorectal cancer, decrease అవుతుంది. ఒక స్టోరీ ఉన్నది. Decrease. Uncertain. Anecdotal reports. Now let's talk about Mullerian agenesis. Most of these things we studied. Mullerian agenesis. Mullerian agenesis law not only, see, the Mullerian duct not only will form the genital system, even urinary system contributory. That's the reason unilateral renal agenesis can occur. Lot of people will have single kidney తెలుసా? అల్ట్రాసౌండ్ దేనికో చేస్తే ఒకటే కిడ్నీ ఉంటుంది. కామన్ ఏంటి? యూనిలేటరల్ రీనల్ ఎజెనసిస్ కెన్ బి ఏ పార్ట్ ఆఫ్ మేయర్ రొకిటాన్స్కీ కస్నర్ హాస్టనర్ సిండ్రోమ్. హవర్ ద ఓవరీస్ ఇన్ ఎంఆర్కేహెచ్ అన్న ములేరియన్ ఎజెనసిస్ అన్న ఒకటే. అర్థమైంది కదా? సో ఓవరీస్ ఆర్ ప్రెజెంట్ because ovaries are not Mullerian duct derivatives. Then do we do IVF in MRKH? IVF is possible using surrogacy. Ovaries are functional. అంటే ఇక్కడ ఏంటి? దీనికి స్వైర్ కి డిఫరెన్స్ ఏంటి? स्वायर में ओवरीज नहीं है, यूट्रस है. इधर यूट्रस है, यूट्रस नहीं है, ओवरीज है. So she can give her egg to her sister. Her sister can carry the pregnancy. Swayerla, his or her will carry a surrogate pregnancy between his or her sister's eggs and his or her husband. Okay? So, do we do IVF in MRKH? Yes. IVF is possible, but they don't have ovary. They don't have uterus. So somebody need to carry that surrogacy. Gurtupettukuntre. So what do we do in MRKH additionally? Vagina's lower third is urogenital sinus, which is still there. Upper part is not there because the upper part is derived from Mullerian duct. So we do the vaginal lengthening. What is that called? McIndoe's vaginoplasty is done to do the vaginal lengthening. Nowadays, uterus transplantation surgery is also available. Brain transplantation కూడా మొదలు పెడతారు మన వాళ్ళు. So now coming to the uterine anomalies. What are all the uterine anomalies? Failure of the fusion of the Mullerian ducts properly lead to the various uterine anomalies. Most common uterine anomaly is arcuate uterus. మర్చిపోద్దు. 35% in arcuate uterus. Then bicornuate uterus is incomplete fusion of Mullerian ducts. మనం మధ్యలో బ్రేక్ తీసుకుందామా? 75కి బ్రేక్ తీసుకుందాం. నిద్ర వస్తుందా?
I'm not able to concentrate.
అవునా? ఓకే. సో कितने घंटे खत्म किए? 1.5 hour. కుదిరితే ఈవినింగ్ ఇంకొక సెషన్ ఇద్దాము.
Yes.
I don't mind coming.
Okay.
I'll finish the OP and all.
Okay.
Then I'll once more evening I'll come.
Okay.
But మనం పూర్తి చేయాలి బంగారం.
Yes.
Okay. So thank you all for joining the session. Evening we will try to have one more session.
Yeah. I'm trying to finish it before you come.
Try చేయండి.
Yeah.
Try చేస్తే at least last 50 pages.
Yeah.
Last 50 pages I'll once more
Yeah.
try to finish. మీరు కొన్ని ఫినిష్ చేస్తే.
Yeah, you can.
Test.
You can quiz.
మీరు go sleep,
Okay.
get up and then take the test.
Yes.
Huh?
Okay.
Adi, that is a promise.
Yeah. Okay.
Now test is a fun for you
Yeah.
because a lot of things you are finishing, right?
Yeah.
So evening, once more we'll try to have another class.